Good evening, doctors. I, Dr. Kishore Rambhau Sonkusran, Medical Advisor, Aquila Division INTAS, welcome you all to this webinar on management of bipolar disorder. The current webinar will be mainly focused on the current management of bipolar disorder, various stages of the bipolar, and according to the which drug to be used in other conditions like age, sex, comorbidity, and what is the goal for the treatment. To moderate today's webinar, I would like to ask Dr. M.S. Reddy to guide us and moderate the session. Dr. M.S. Reddy has completed his MD from CMC Vellore and Healthcare Management at Indian School of Business. He is the director of Asha Bipolar Clinic in Hyderabad. He is past president of IBP and IABP and the honorary secretary of Society for Bipolar Disorder India. He is also the editor of Indian Journal of Psychological Medicine from 2006 to 2017. He is a council member of Indian Network of Bipolar, Asian Network of Bipolar Disorder, council member of Asian Association of Neuropsychopharmacology. He is also a member of editor board of World Journal of Bipolar Psychiatry and the member of editor board of Asian Journal of Psychiatry. So without taking much time, I'll hand over the session to the MS Reddy sir. And I request all the attendees to kindly drop your questions at QA box or chat box, which can be answered at the end of the session. Thank you. Happy learning. Over to you, MS Reddy sir.
Thank you. Thank you very much, Dr. Kishore. And then good evening and then welcome you all. Anytime, any session on a bipolar disorder is most welcome for me. I would love to sort of hear people talking on bipolar disorders because with a little bit more of a special interest on that, I look forward to new learnings. And especially, I think all of you must have seen today's topics are really excellent topics and not easy topics, very difficult topics. First thing is Dr. Vikas is going to talk on DSM-5 defined mixed state bipolar disorder because the mixed state is one thing I always have a problem in both diagnosing and managing. For a long time, I was thinking that how do we, then DSM-5 removed that category broadly. I was very happy, but they have added that mixed specifier under MDD. I think Vikas is going to talk about it. Today, the flow of events is going to be Dr. Vikas Menon will be the first speaker who is going to talk on the pharmacological management of DSM-5 defined mixed bipolar disorder. Dr. Vikas, I think almost all of you know, he's an additional professor for psychiatry at JIPMER. He's got special interest in mood disorders and then some lot of work on suicidology and also digital psychiatry. And about more than 2 decades of experience, 150 publications. I'm very happy that he is actively involved in both Indian Journal of Psychological Medicine and also Indian Journal of Psychiatry. So he'll be the first speaker, maybe about 20-25 minutes. After that, Dr. Suresh Kumar will be the second speaker who is going to talk on non-pharmacological medical management. Again, a very, very interesting topic. Once both of them finish that, then we'll have some time for the question answer session. As has been now requested, please drop all your questions in the question answer session. At the end of both the speakers' presentation, we will take up the question answer session. I'm sure it's going to be a very, very lively meeting. The next 1 hour is going to be. With these few words, I invite Dr. Vikas to initiate his presentation and share his slides. Dr. Vikas, over to you.
Thank you, sir. Thank you for the kind introduction, sir. Am I audible?
Yes, very much.
Yes, sir. Just a minute. I'm just sharing the screen. Yeah. I hope my screen is visible.
Right. Yeah, definitely.
Yes, yeah.
Okay. So, good evening to everyone who has logged in, respected moderator and all the organizers of this webinar. Thank you for giving me this opportunity to be here on this day and share some thoughts about a topic which is also very challenging diagnostically and for clinical management. I hope at the end of the next 25 minutes, we'll have some clarity on this. So the topic given to me is pharmacological management of DSM-5 defined mixed mood states. And over the next 25 minutes, this is how I propose to structure the presentation. First, we'll talk about the conceptualization of mixed states and how it has undergone a change from DSM-4 to DSM-5 that will hopefully set the background for understanding, because there's a lot of difference in the way DSM-4 and DSM-5 have conceptualized mixed states, and therefore the management also differs. Then we'll talk about some general principles of management of mixed states. Then the pharmacological strategies for bipolar mania with mixed features, and separately for bipolar depression with mixed features, because the strategies are different. And then at the end, I have two clinical case vignettes, which I have synthesized from my experience, and I hope that we can discuss that also a bit, because there are certain areas where experience you need to synthesize along with the evidence in order to sequence treatments for mixed states. So first, what is the change in conceptualization of mixed states from DSM-4 to 5? So DSM-4, as you may know, has used the term mixed episodes. So that is a very, very restrictive term, which had individuals who needed to satisfy the full syndromal criteria for mania as well as depression, except obviously for the duration criteria, because it was for a week that they had to satisfy the full syndrome of mania as well as depression. So that was a very restrictive definition, and all of us, when we were practicing with DSM-4, we recognized that there were many individuals who fell below these threshold definitions, but we could not do much about it. So recognizing these limitations, DSM-5 has done away with the term mixed episodes and introduced something called the mixed features specifier. So here, for example, if you're talking about a manic episode, then you need to have 3 episodes, 3 contrapolar symptoms, that is 3 symptoms from the opposite pole, that is depression. And they actually give a list of what are the symptoms which are allowed or permitted to be included as from the opposite pole in order to make a diagnosis of mania with mixed features. Similarly, you can apply this mixed features specifier to also depression, to also hypomania. So to any episode type, you can actually apply this mixed feature specifier. So what DSM-5 has done actually is recognize or legitimize a lot of subthreshold presentations of these mixed states. But at the same time, it also makes the diagnosis and management a little more complicated than the mixed episodes in DSM-4. So that's what we are trying to discuss here. This is another picture which, for me, it was easy to understand the difference between DSM-4 and DSM-5 by looking at this picture of conceptualization of mixed states. So I hope the cursor on my screen is visible. So DSM-4, what it did is there were discrete islands. As you can see, there were discrete islands of mania, depression, and mixed episodes without any connection between each other. So I would like to conceptualize this as 3 separate countries where individuals needed, say, a visa or a passport to move between these countries. But you see DSM-5 here below. So there, it is along a continuum that they have conceptualized manic states, mixed states, and depressive states. Obviously, mania and depression come at the 2 ends of this continuum or spectrum, and in between you have these mixed states, which could either be mania with mixed features, which is more closer phenomenologically to the manic episode, and the depression with mixed features, which is phenomenologically more similar to depressive episodes. So it's like a single country now, where individuals can freely migrate between these states. And that's how also maybe we can think about the conceptualization of mixed states as far as DSM-5 is concerned. So as you can see here, DSM-5, mania with mixed features, means they should have 3 contrapolar symptoms, at least 3 contrapolar symptoms from the depressive polarity. And similarly, for depression with mixed features, 3 manic symptoms, that is 3 contrapolar symptoms, apart from fulfilling the syndromal criteria for depression, which is more than or equal to 5 of the 9 symptoms that are listed in DSM-5. Similarly for mania. So yeah, just another slide on comparative nosology to summarize what we have spoken so far. So DSM-4, the criteria for mixed episode is the criteria should be met for both manic episode as well as major depressive episode for 1 week. DSM-5 has now done away with that. So it is now full criteria for an episode, whether it is mania or depression, and at least 3 symptoms from the opposite pole. So if it is mania, then 3 symptoms from the depressive pole, and likewise for depression. What does ICD-10 say? ICD-10 told us that it is co-presence or rapid alteration of depressive, manic, and hypomanic symptoms for at least 2 weeks. So ICD-10 actually did not have as restrictive a definition as DSM-IV. It recognized a lot of subthreshold presentations also. In fact, for all of us, it was easier to diagnose mixed affective episode as far as ICD-10 was concerned. And then ICD-11 has more or less, of course, the draft ICD-11 has more or less retained the classification of ICD-10 in the sense that mixed episode is going to be retained. The only difference perhaps is that ICD-11 is going to provide a list of contrapolar symptoms from which you will have to pick and choose when you are going to make a diagnosis of mixed episode. So that way ICD-11 and DSM-5 differs, because ICD-11 is going to retain the mixed episode term. So now coming to having known the difference in conceptualization between DSM-IV and DSM-5, now we'll talk about the management proper, that is general principles in the management of mixed states. So first, what we have to understand is that now when we are trying to manage DSM-5 mixed states, will evidence based on DSM-IV criteria, that is just can we extrapolate the DSM-IV mixed episode and the trials that have been done on DSM defined, who have defined patients based on DSM-IV criteria, can we directly take that and apply to DSM-5? It may not apply entirely, because as we just now discussed, DSM-5, a lot of subthreshold presentations are also now legitimized in DSM-5, whereas DSM-IV only recognized the most severe mixed states as the full mixed episodes. So that is something that we have to keep in mind. So now what do we need to do? If we are going for evidence-based management, we need to look for evidence on trials that have defined individuals or intake of participants based on DSM-5 criteria. And if you do a literature search, you will find that there is actually insufficient evidence based on DSM-5 mixed states criteria. In fact, if you go strictly by level 1 recommendation, no agent would meet level 1 recommendation for DSM-5 mixed states. Now, as you know, level 1 recommendation means evidence from a meta-analysis or evidence from at least one large, well-conducted, well-analyzed RCT or multiple small replicated RCTs. So we do not have agents which meet level 1 recommendation. So we'll have to go for maybe level 2 or something like that. So we will see the evidence. Now, earlier the teaching was that quite simple, that mixed episodes, as far as management, you equate it with a manic episode. So we all used to treat with mood stabilizer and antipsychotics. That may still apply now to mania with mixed features, but for depression with mixed features, maybe we may need to recalibrate our approach. We'll see each of that individually, one by one. So therefore, since there is no level 1 evidence for DSM-5 defined mixed states, the recommendations that I'm going to make here will be based on 3 or 4 considerations. That is, wherever possible, based on an analysis of studies which have specifically studied DSM-5 defined mixed mood states, based on an educated generalization of studies which have evaluated DSM-4 TR defined mixed episodes. Wherever possible, we will see where we can extrapolate the evidence from there to guide management of DSM-5 mixed states. And of course, the CANMAT ISBD guidelines, which was released in March 2018, from there also I have taken material. And finally, I have also synthesized some of this data with my own clinical expertise while I try to, that's what I will be discussing in the 2 case vignettes at the end. So this is what we will be doing. So initially, just as for any other mood episode, accurate diagnosis and characterization of the episode is very important. That means that we try and simplify by looking at the predominant polarity. Is it primarily a mixed mania or a mixed depression? This is perhaps the first thing that we should do when we are dealing with DSM-5 mixed states. So just going back to the spectrum concept, this is what we discussed. So we need to find out whether our individual is experiencing mania with mixed features or depression with mixed features. Now, suppose they are presenting as the first episode, depression with mixed features, then you need to be very careful and look for any past history of mania or hypomania so that you don't miss out any underlying bipolarity. Then, once you do that, then you need to closely monitor for treatment response. For this, we all use symptom checklists, rating scales, You are allowed to do that. That's a very good method of monitoring for treatment response. And you also need to look for any adverse effects, because keep in mind, people with mixed states, people who are experiencing mixed states, are more prone to adverse effects like affective switch. So it has been documented that people who have mixed features are more likely to switch. They are more likely to switch during the episode, and they are also more likely to switch after resolution of the episode. So the close monitoring has to be continued even after the episode has remitted. So people who have mixed features, they are more likely to declare themselves as bipolar later on. So we need to closely monitor for treatment response even after episode resolution. Second thing that we need to look for is the suicidality. So people who are experiencing mixed features are more prone to have suicidal ideation, more prone to have suicidal attempts. So that is another thing that we should closely monitor for. And the last thing is, there is also a syndrome called activation syndrome, which is a clustering of 10 symptoms. Among that would come panic, anxiety, agitation, insomnia, hostility, aggressiveness. These are all more likely in people with mixed features. And why this is important is because the FDA has recognized that a clustering of these symptoms is actually a precursor for suicidality. So maybe if we miss activation syndrome, we may miss that it is a harbinger of suicidality. So these are the things that we need to monitor for. Now, although the mainstay of treatment of mixed states is pharmacotherapy, we also need to look at psychotherapy. Hence, individual and family psychoeducation should be provided to all patients. Here, mainly, we will be focusing on, apart from the general aspects of psychoeducation, two things specifically to focus on are early warning signs of affective switching or relapse. So these two things we need, because these people are at a more increased risk of a more protracted illness course. They have more relapses, more suicidal attempts, and so on. So that should be provided to everybody. Currently, there is insufficient evidence for psychosocial treatments as monotherapy in mixed states, unlike, say, for example, in a unipolar depression. So psychosocial therapy should be provided as an adjunct to pharmacotherapy. The general principles of choosing a treatment agent are just like any other mood episode. So you would go by the adverse effect profile, the tolerability profile, the medical comorbidities. So as and when those principles are coming up, we will be discussing that in the between the presentation as well as in the final case vignettes. Now, the primary goal of management, we divide that into acute phase, maintenance phase, a continuation phase, and maintenance phase. So there are three phases of treatment for even the mixed states. So acute phase, the management goal is to alleviate the symptoms, to induce remission of symptoms. Now, remission means near total improvement in symptoms with return of socio-occupational functioning, and reduce risk of harm to self or others. In the continuation phase, the goals are to consolidate the treatment gains that have been made in the acute phase, to treat whatever symptoms may be remaining, and to prevent a relapse. And finally, maintenance phase treatment goals are to prevent recurrence of the episode. Now the patient has kind of remitted from the episode, so you want to prevent the recurrence, reduce any residual symptoms. There is a lot of burden of residual symptoms in mood episodes, so you want to reduce that, and also improve the functioning by various pharmacological and non-pharmacological techniques. Now, when we talk about mania management with mixed features, management of mania with mixed features, then we'll go to depression. There are only 3 trials so far for DSM-IV defined mania with mixed features. 2 of them were on mania with mixed features. 1 of them was on hypomania with mixed features. The first trial was published fairly immediately after DSM-IV came out. This was by McIntyre and colleagues in Journal of Affective Disorders in 2013. Now, this was a post hoc analysis of 2 identical RCTs. The RCTs were originally done for comparing asenapine and olanzapine monotherapy versus placebo in bipolar mania. Once the DSM-IV came out, the same investigators pulled out data from those individuals who satisfied mania with mixed states definition. So that is why it's a post hoc analysis. There are problems involved in doing such a post hoc analysis, but it is better than having no evidence at all. So this pooled post hoc analysis showed that asenapine and olanzapine monotherapy was superior to placebo for DSM-IV mania with mixed states. So these are 2 antipsychotics with evidence. The second trial was done by Tohen and colleagues a year later. This was again a post hoc analysis of 3 identical RCTs. All of them studied olanzapine, and it was found that when they pulled out data from mania with mixed states patients, olanzapine group had greater reductions in both manic as well as depressive symptoms. The effect size was around 0.25, which is a moderate effect size. And this was a trial, the only trial so far on bipolar 2 hypomania with mixed symptoms. Here in this randomized control, this was not a post hoc analysis, this was a prospective RCT. So it carries more weightage. Patients were randomized to receive either quetiapine or placebo. The results were somewhat not too robustly, pointing towards efficacy for quetiapine. Quetiapine was more effective for depression symptoms, but did not have robust anti-manic efficacy in this trial. So that was a little bit of a dampener. You can also go to pre-DSM-IV era to look for evidence that might guide you for management of mania with mixed features, because as we discussed earlier, the pre-DSM-V evidence may apply more to mania with mixed features than depression. So these are two important systematic reviews in the pre-DSM-V era. When you take these trials in toto, the evidence says that atypical antipsychotics and divalproex are first-line treatments, and they have good efficacy for both mania and depression symptoms. As far as second-generation antipsychotics are concerned, they have good evidence, better evidence for mania with depression. For depressive mixed states, there was only 2 trials, hence the authors concluded that we need more evidence and evidence is unclear. The other major point from these 2 reviews were that combination therapy was superior to monotherapy. So that is that a combination of mood stabilizer and antipsychotic was superior to a mood stabilizer alone as far as mania with mixed features management is concerned. Now this is more or less concurrent with our day-to-day practice also, where we know that most of the patients tend to receive combination treatments than monotherapy. So here is actually some evidence for what we are actually doing in practice. Yeah, are there any agents to avoid when you're managing mania with mixed features? Yes, you need to avoid antidepressants, because for obvious reasons that you don't want to precipitate an effective switch or destabilize the mood. For same reasons, you may also want to avoid psychostimulants. Judicious use of benzodiazepines and Z drugs, because you need to actually, it may be very beneficial in the beginning of therapy, because you may want to normalize sleep as quickly as possible, because it has been found in many studies that normalization of sleep is linked to a faster remission of symptoms. But long-term use of benzodiazepines and Z drugs are also associated with depressive symptoms, so you might want to hold off these drugs once you have entered the continuation phase. So summarizing mania with mixed features before we move on to depression, the first-line treatments are to discontinue all antidepressants and psychostimulants and consider short-term use of benzodiazepines. Monotherapy, you may want to consider any of these agents in isolation. These are all agents which have divalproex, aripiprazole, ziprasidone, quetiapine, risperidone, asenapine, and lithium. Now for including these agents, I've also included evidence from the CANMAT guidelines. Adjunctive treatments to lithium or divalproex may include any of these antipsychotics, which are mentioned here. Second line, if once you've finished all these first line options, you may want to go for second line treatment of monotherapy with lithium and typical antipsychotic haloperidol and olanzapine. Olanzapine here is downgraded to second line because of its adverse effects in terms of weight gain and metabolic side effects, not because of lack of efficacy. And adjunctive to lithium or divalproex, you may want to try haloperidol or olanzapine. Third line treatments are monotherapy with clozapine or carbamazepine, or adjunctive treatment with carbamazepine or clozapine in combination with lithium or divalproex. There is also emerging evidence for allopurinol, tamoxifen, and for blue blocking glasses, which is similar to dark therapy. So the orange tinted glasses. There are RCTs on each of these. In fact, for allopurinol, there's also a meta-analysis. So these are probably that agents that we can try in resistant cases. ECT also possible, an option in resistant cases, and you may want to advance this ECT to more of a first line treatment when there is severe risk of harm to self or others, or when the patient is not taking proper diet or nutrition. Not recommended antidepressant monotherapy and all these agents which are also touted as mood stabilizers, but which do not have much evidence in RCTs. Before moving on to depression, this is the final slide I have for mania with mixed features. This is a network meta-analysis which allows head-to-head comparison between various agents. Of course, this is not specific for mixed states, but for acute bipolar mania. So as we can see below, all these agents, oxcarbazepine, lamotrigine, licarbazepine, and verapamil, do not have positive evidence, and therefore these are to be avoided. All the agents that we discussed, risperidone, haloperidol, olanzapine, and all have good efficacy. So maybe we can choose from these agents. Moving on to depression. So results from mixed episode studies, especially pre-DSM-IV, are more generalizable to mania with mixed features. We need to recalibrate our approach to depression with mixed features as far as DSM-IV definition is concerned, because depression with mixed features are more associated with a more severe course of illness, more severe depressive symptoms, higher rates of substance use, and cardiovascular disease. So we need to really choose our management options more wisely. Again, as discussed earlier, before beginning drug treatment, you need to evaluate for history of mania or hypomania so that we don't miss any underlying bipolarity. There are two trials here that we should be aware of. These are probably the two trials that are available for DSM-IV defined mixed states. One was a randomized double-blind placebo-controlled trial of ziprasidone for acute depressive mixed states. Here, 73 patients were enrolled, and all of them had fulfilled criteria for DSM-IV depression and 2 to 3 manic features. So that is very similar. Remember, the definition for DSM-IV depression with mixed states is depression with 3 manic symptoms. So that's very similar to the definition they've used. Overall results were that ziprasidone was superior to placebo for improvement on depression rating scales, and encouragingly, the improvement was more robust in bipolar 2 compared to major depression. There was no difference in mania scores, and that's also encouraging because that means that there was no risk of switching or no risk of mood destabilization. The second trial was specifically on bipolar depression with mixed features. Here, the inclusion criteria was bipolar depression with YMRS more than or equal to 4. Lurasidone outperformed placebo for depressive symptoms, and again, rates for treatment emergent mania were similar, not statistically different in the two groups. So that means that there was no mood destabilization. So lurasidone and ziprasidone, there are trials on DSM-IV defined mixed states. There are also other post-hoc trials that exist for bipolar 1 depression. One was by Benazzi and colleagues, which showed positive effects for olanzapine and olanzapine fluoxetine combination in bipolar 1 depression with mixed states. In fact, in this trial, the definition they used was MDE with more than or equal to 2 manic symptoms. So that's again very similar to the DSM-IV mixed states definition, depression with mixed states definition. By the way, olanzapine fluoxetine combination here had an odds ratio for response of nearly 4. That was twice as much as olanzapine, which had an OR of 2. So the olanzapine fluoxetine was found to be superior to olanzapine alone in the management of depression with mixed features. Why this is important, I'll come to when I discuss the case vignettes. The other post-hoc analysis was conducted by Tohen et al. So this was a very interesting post-hoc analysis where they actually divided depression with mixed states into depression with 1 manic symptom, depression with 2 manic symptoms, and the last one was depression with 3 manic symptoms, which is exactly similar to the definition for depressive mixed states in DSM-V. So olanzapine was superior in all these categories compared to placebo. So olanzapine is another agent with evidence for depression in mixed states. So to summarize, SGAs with evidence for DSM-V depression with mixed features are ziprasidone, lurasidone, olanzapine, and olanzapine fluoxetine combination. Now, what about the missing elephant, that is quetiapine? That is prominently highlighted in all the CANMAT ISBD guidelines, but the fact of the matter is there is no RCT for quetiapine in mixed states. What about cariprazine or lithium? Same problem. Cariprazine is probably effective because it has been shown to be effective in DSM-IV defined mood episodes, but there is no RCT as yet on DSM-V defined mixed states. ECT, we discussed, it could be a third line option, or you could advance it when there is suicide risk. Any agents to avoid? Yes. Agents like gabapentin and levetiracetam do not have evidence in DSM-V defined mixed states and should be avoided. So this is to summarize the DSM-V defined depression with mixed states algorithm. Monotherapy, probably you should be looking at lurasidone, ziprasidone, and asenapine. Asenapine is recommended in the CANMAT guidelines. Adjunctive treatment may be again lurasidone. Monotherapy, you could look at second line options for monotherapy, asenapine, olanzapine fluoxetine combination, or lithium. Adjunctive to lithium or devalprex, you could consider ziprasidone or asenapine. Third line, you could consider combination treatment, different antipsychotics than what you have tried in first line and second line, in combination with mood stabilizer, of course, or ECT or lamotrigine, especially for depression predominant course of illness. As we discussed, agents to avoid are antidepressants and adjunctive levetiracetam or gabapentin. I have two case vignettes with which I will summarize. I will read out the first case vignette. Mr. J is a 27-year-old gentleman with bipolar disorder. He presents with irritability, increased goal-directed activity, racing thoughts, inflated self-esteem, and decreased need for sleep. Simultaneously, also experiences decreased interest in activities, fatigue, and feelings of worthlessness. There is marked agitation and excitement upon presentation. So what's the diagnosis and what are the first-line pharmacological agents in this case? I will just present the answer to you. So the diagnosis is bipolar 1 disorder, current episode, manic with mixed features. I think that is clear. Now, evidence says that we should start mood stabilizer plus antipsychotic and plus minus benzodiazepine, depending on the degree of agitation and excitement. Which mood stabilizer will you choose? You could choose lithium or valproate. Both have good evidence here. Valproate you might want to avoid in women of reproductive age group. Antipsychotics, which one you would like to choose? You might like to choose any of these, olanzapine, risperidone, or aripiprazole as first line. If there is a personal or family history of diabetes or obesity, you might want to avoid olanzapine. Coming to the last case vignette, I will read this. Mrs. A is a 32-year-old lady with bipolar 1 disorder. She presents with pervasive sad mood, diminished interest or pleasure in activities, fatigue, feelings of worthlessness, and recurrent thoughts about death, insomnia, and recurrent weight loss. Simultaneously, she also experiences racing thoughts, increased talkativeness, and at times increased goal-directed activity. She's a known case of hypothyroidism on replacement therapy. What is the diagnosis and what are the first-line pharmacological agents in this case? Here also the diagnosis is pretty clear that it's a bipolar 1 disorder, current major depression with mixed features. Now, evidence here says that you could try lurasidone monotherapy as a first-line option or as an adjunct to valproate. But here is where the experience slightly differs for me, at least. I have found a better response with SSRI plus a mood stabilizer. So that is what I usually start for people with depression with mixed features. Now, if there is hypothyroidism, I might want to avoid lithium, pre-existing hypothyroidism, and go for SSRI plus a second generation antipsychotic, which works just as well, in my opinion, compared to SSRI plus mood stabilizer. The SGA that I would choose would be again olanzapine, risperidone, aripiprazole. If there is history of obesity or diabetes, I might like to choose risperidone or aripiprazole. So to conclude, DSM-IV has replaced mixed states with mixed feature specifier, and this basically legitimizes a lot of subsyndromal presentations of the mixed state. Mixed features are associated with more chronic severe course and suboptimal treatment responses. Emerging evidence indicates that some atypical antipsychotics may be effective in treating DSM-V mixed states. Clinical experience differs with guidelines in certain areas. Going by the predominant mood polarity appears to be a reasonable starting point. So when you say mixed features, first try to determine whether it's mania with mixed features or depression with mixed features and treat accordingly. That kind of simplifies the management. And clinicians, all of us need to combine treatment guidelines with our individual experience and make decisions regarding sequencing treatment for mixed states. These are some of my references. I thank you for a patient listening and hand over the session back to the moderator. Thank you, sir.
Thank you. Thank you very much, Dr. Because it's like a wonderful presentation. I know it's a very difficult task to talk about the mixed cases. But I'll just one or two points, maybe later it can be taken up for discussion. Yes, before we go to Suresh Kumar. The presentation was bipolar mixed cases. But like under in the DSM-V, MDD, they give as a specifier mixed features. Yes. That is what my main worry is about. And that, how do we manage if you make a MDD diagnosis and mixed features? How are we going to manage? That's going to be the like a very, very interesting point there. And I'm happy because when you talked about the second case, Vignette, you talked about SSRIs being more useful in the management of depressive phase, which I think generally a lot of evidence is talking about no antidepressants, I think, which you yourself have mentioned. Maybe later we can take it up for discussion later. Thank you very much.
Yes,
wonderful presentation. Now we welcome Dr. Suresh Kumar, who is a professor of psychiatry at KMCT Medical College. He's going to talk on non-pharmacological medical management. I'm really interested to know what exactly non-pharmacological medical management he's going to do. I think CV of Suresh Kumar runs into almost about 20 pages. All of you know he is a professor of psychiatry. I'm amazed that he has got almost about 30, more than 30 awards, more than about 150 publications, and then he has written chapters in about more than 20 chapters. Amazed at his energy levels and all that. Congratulations, Suresh Kumar, and then welcome to you. And then your presentation is going to be for the next 20-25 minutes. After that, we'll take up the question answers. Over to you, Dr. Suresh. You have to unmute yourself, Dr. Suresh. No, you have to unmute. No. Video is clear, but you have to. All right.
Am I audible now?
Yes,
sir. Yeah.
Okay.
Yeah.
Good evening, everybody. First of all, I would like to thank the organizers and the respected chairperson and also Dr. Vigas for giving me an opportunity to talk on this topic, non-pharmacological medical management of bipolar disorder. So straight away, I am entering to the topic. Already, Vigas has given a platform about the pharmacological management of bipolar disorder. So here, just I will be touching only on the non-pharmacological medical management of bipolar disorder. See, there are three.
Dr. Suresh Kumar, can you make
Yes.
it the full screen, sir?
Yeah. Is it a full screen?
Yes, sir. It's clear, sir. Yeah. Thank you.
Okay. So there are three main treatments of interest in non-pharmacological management of bipolar disorder. These are mainly chronobiological aspects, neurostimulation, and invasive therapies. So in chronobiology, I'll be touching on light therapy, sleep manipulation techniques, and dark therapy. In neurostimulation, I'll be touching on transcranial magnetic stimulation, transcranial direct current stimulation, and electroconvulsive therapy. In invasive therapies, there are mainly two types of therapies. One is deep brain stimulation and vagus nerve stimulation. So coming to chronobiology, we know that depressed and manic patients, they will exhibit a substantial disruption of various biological rhythms. In all these biological rhythms, we'll be focusing on mainly the sleep-wake cycle. So we know that depressed patients, they will be awake during night. They have early morning awakening. They will be feeling tired and they sleep excessively. Sometimes they sleep excessively during the daytime. Whereas manic patients, they are the opposite pole. They have got less desire for sleep. Usually they will show hyperactivity. So we can see a definite changes in the biological rhythm in the sleep-wake cycle of depressed patients as well as manic patients. Some of these alterations, it can follow an infradian periodicity. That means the disrupted rhythm is longer than a day. Then it could be an ultradian rhythm also. That is disrupted rhythm, it is shorter than a day. And usually most of these rhythm are circadian. That is disrupted rhythm that lasts approximately 1 day. We know that melatonin regulates the sleep-wake cycle. Melatonin secretion is usually maximum at midnight, and melatonin is inducing sleep. It is a sleep-inducing hormone. Studies indicate that there is an alteration in the secretion, the peak secretion of melatonin in subjects with bipolar disorder. Sunlight is the external signal which is recognized by the molecular clock, that is a suprachiasmatic nucleus of hypothalamus, that is a major circadian pacemaker. Variations in sunlight exposure and the photoperiod, these are the main pathogenic factors for seasonal mood disorders, and also this will contribute to the susceptibility in bipolar disorder. So, in the light of these observations, a variety of chronotherapy techniques have been recently used in the management of bipolar disorder. So, when we come to the chronobiological treatment modalities in the management of bipolar disorder, first one we can discuss about sleep deprivation. The actual mechanism of action of sleep deprivation bipolar disorder is not yet known. We all know that when a person is awake, there is an increase in the dopaminergic, noradrenergic, and serotonergic activity. Whereas when the person is sleeping, there is a reduction in the dopaminergic, noradrenergic, and serotonergic activity. And all these excessive activity of these neurotransmitters during awake and the diminution or reduction during sleep is particularly prominent in bipolar depressed patients. So studies indicate that there are similarities between the activity or between the action of SSRIs and sleep deprivation in terms of serotonergic firing and autoreceptor 5-hydroxytryptamine 1A stimulation. So there is a similarity in the mode of action of SSRIs and sleep deprivation at the neuroreceptor level, especially at the serotonergic firing and the 5-hydroxytryptamine serotonin receptor level. Functional polymorphism of the gene that controls serotonin transporter that predicts the response to antidepressants as well as sleep deprivation therapy. So the here also it shows that the mechanism of antidepressants and sleep deprivation may be almost same. So that is why we are using sleep deprivation as a modality of treatment, as a non-pharmacological treatment in the management of bipolar depression. There are different models for sleep deprivation. Usually, what we are employing that it's a 36 hours of forced wakefulness, which is followed by a night of rest. And this is a repeated scheme. We have to repeat it 3 times consecutively. Most useful therapy, sleep deprivation therapy in terms of efficacy is total sleep deprivation therapy. So when we look at this total sleep deprivation protocol, here we can see that the person will be awake from 24 hours plus 12 hours. That means 36 hours we are forcefully keeping the patient awake. And this is followed by a period of 12 hours period of rest. And then again, there will be a 36 hours of complete wakefulness. Again, period followed by a period of rest. And there will be three consecutive cycles of forced wakefulness followed by a period of rest. This is the usual sleep deprivation protocol, which is found to be effective in the management of bipolar depression cases. See, studies indicate that sleep deprivation therapy in the management of bipolar depression, it has got a rapid mode of action. All of us know that it is well tolerated than any of the pharmacological therapies. It's a non-invasive therapy, and it is a valid and safe alternative to pharmacotherapy. It can be used as an augmentation of antidepressant pharmacotherapy. It can be given in rapid cycling bipolar patients who don't show satisfactory response to lithium. It can also be given in patients in bipolar disorder patients where antidepressants will exacerbate cyclicity. So whenever there is a worsening of the course of bipolar disorder, with antidepressant, or if the patient is switching to mania, there is an option of sleep deprivation therapy in bipolar depression. Now, what are the limitations of sleep deprivation therapy? There is a high rate of early relapse. It is showing in bipolar depressed patients. Rarely, it can precipitate mania. So, in order to minimize these limitations, we can use total sleep deprivation therapy and light therapy in conjunction with an established mood stabilizer. Usually the ideal mood stabilizer to combine with total sleep deprivation and light therapy is lithium. Why we are using lithium? Lithium can produce a synergistic effect on serotonergic system. It will desensitize 5-hydroxytryptamine 1A autoreceptors, and thereby it will induce neuronal depolarization. Now, what is the evidence of efficacy of sleep deprivation in bipolar depression cases? See, so far there are only mainly open label studies showing the efficacy in bipolar depression. It is found to be efficient as a therapeutic and prophylactic method, and most of these studies have shown that it's a well accepted and tolerated method of treatment in bipolar depression. But most of the studies, when we look at the severity of the depression, is only mild to moderate. And in many of these studies, sleep deprivation therapy has been used in conjunction with an established mood stabilizer, mostly lithium and sodium valproate. Now, coming to another type of therapy in bipolar depression, that is light therapy. We all know that there is a direct connection between mood, sunlight exposure, and sunlight intensity. Sunlight is the stimulus which is recognized by the suprachiasmatic nucleus of the hypothalamus. So the sunlight will inhibit melatonin secretion, which is secreted by the pineal gland, and this is the main regulator of the sleep-wake cycle. So this circuit, this suprachiasmatic sunlight, retinohypothalamic tract, suprachiasmatic nucleus of hypothalamus, ultimately pineal gland, and melatonin production. This circuit is altered during the depressive episodes, and this is influenced by light therapy. So this is the basis of light therapy in the treatment of bipolar depression. Like in sleep deprivation therapy, in light therapy also, there are different protocols. The most consistent evidence comes from the light devices with a power of 10,000 lux, which is used for at least 30 minutes, administered early in the morning. If possible, the day period of light therapy that can be customized by using a morningness, eveningness questionnaire score, which is a self-administered scale that assesses the tendency to be more active in the morning or more active in the evening. So in this scale, if it is found that the person is, if the score, morningness score is high, that means the person is more active in the morning. So we can give light therapy at morning. If the score is found to be high at the eveningness area, then we can give light therapy at evening. Like that, we can customize this light therapy depending upon the activity of the person, whether it is at morning or at evening. So in these different protocols, midday light sessions have been found to be beneficial in small studies. Usually, light therapy can be used in combination with the total sleep deprivation, then that will produce more robust response in bipolar depression. Coming to the evidence of efficacy, unfortunately, studies are very limited, especially from our country. There are only mainly case reports. It gives both positive and negative results. It is mainly recommended in ultra rapid cycling conditions and ultra rapid cycling pattern also. As we all know that light therapy is a well-tolerated treatment. Now, coming to another type of therapy. Now, so far we discussed everything about bipolar depression. Sleep deprivation therapy is a treatment modality for bipolar depression. Light therapy, exposure to light, is a therapy for bipolar depression. Now, can we use this type of chronobiological therapy in the management of in the non-pharmacological management of manic episodes? So, sleep manipulation is also useful in treating manic episodes. Chronobiological theories are valid for explaining psychopathology of mania also. If depressed patients can be treated by exposing them to light, or if they can be treated by taking away their sleep, then why don't manic patients, we can treat manic, why don't we treat manic patients by giving them, by inducing them sleep, or by giving them more darkness? So this can be well thought of as a treatment modality in the management of mania. So some of the techniques for the management of mania in the chronobiological treatment is we can extend the sleep period in a manic patient for more than 12 hours per night. We can we can induce more sleep in manic patients. We can put them in a dim light room with a low level of stimuli. So in all these modalities, the anti-manic effect is maximized when the intervention occurs within the first 2 weeks of illness. What are the advantages of this therapy in comparison with the pharmacological therapies? Dark therapy has got a rapid onset of action. When we are giving more sleep to a manic patient, the symptoms will improve fast. It's a natural therapy. It will reduce the use of, and all these patients, they need concurrent use of antipsychotics and as well as mood stabilizers, usually. So it can, when we are giving antipsychotics, with the dark therapy, we can reduce the use of antipsychotics, thereby we can lower the side effects. Chronobiological treatments work as a safe mood stabilizer. We can see, all of us know that antidepressants can make bipolar disorder worse. It can worsen the cyclicity. Sometimes it can precipitate mania. Light is exposure to light. So light is an antidepressant. So conversely, we can think whether darkness is a mood stabilizer. So the idea of using darkness as a mood stabilizer has been considered for several years. In 1998, there is a case report from NIMH where a carefully timed therapeutic darkness, it was found to have a dramatic mood stabilizing effect. Subsequent RCT of darkness as an adjunctive anti-manic therapy was found to be very effective. So, ironically, in real life, what is happening that in our real life, darkness is very hard to achieve in our modern electric world. See, in nighttime, all of us are using televisions, tabs, smartphones. So that will expose the patients to levels of light, which is sufficient to shift the circadian rhythm. However, all the spectrum, different spectrum in the light are not equal. See, blue wavelength length, blue light have the strongest impact on sleep-wake cycle. Human eyes contain not just rods and cones, it also contains a third circadian photoreceptor, whose fibers connect to suprachiasmatic nucleus of the hypothalamus, primarily the seat of biological clock. In this third circadian photoreceptor, where actually the blue wavelength light is acting on. So that is the origin of virtual darkness. If blue light is the primary wavelength, signaling daytime to the biological clock, blocking the blue light, that can create an equivalent of circadian darkness. Then one can have the darkness, but there will be enough light to work or to play at the same time. So if the blue light is blocked, there will be darkness, but at the same time, the person will have enough light to work or play or do anything. So that is the actual meaning of virtual darkness. So for blocking blue wavelength light only and to transmit the rest of the visible spectrum, we have got amber lenses. So by blocking only the blue wavelength, we can preserve melatonin production, melatonin secretion in a lighted night-like environment or even during the simulated shift work. So this can be used for bipolar patients to provide this amber lens by blocking only the blue wavelength, which we can use for providing virtual darkness in bipolar disorder patients. So that will improve the sleep, thereby it can produce a mood stabilizing effect. The cost of amber lens is very minimal. It can decrease the sleep latency, so the person will get sleep immediately, even when other self-luminous like TV or other tabs are in use. It can facilitate sleep regularity and thus circadian regularity. It will help the patient to stay closer to the natural diurnal circle in which sun itself can reinforce the circadian rhythmicity. What are the risks of using amber lenses? Amber lens is made of plastic, so plastic could be broken and the sharp edges can rarely be used for self-harming. So we have got other alternatives like LEDs, light emitting diodes, and other light bulbs that can emit no blue light but other spectra of light. Now coming to triple chronotherapy, it's a combination of sleep deprivation, morning light therapy, and then deliberate circadian phase advance, making the patient to get up earlier. Depending upon the severity of depression, we can give the patient circadian phase advance. So this triple chronotherapy can accelerate and sustain the response, which is superior to medication alone in bipolar depression. Now, another concept is dawn simulators. Like light therapy, where we are exposing the patient to 10,000 lux of light. Here, it is a cheaper version of light therapy. It's a simple technology that can offer virtual sunrise that can be manipulated to suit the patient's schedule. Like our wake up alarm, we have got a virtual sunrise uh, mode. Dawn simulators can be used. Dawn simulators can improve the cognitive function in the morning. It is also used in some other physical disorders also. It can reduce the cardiovascular accidents by slowing down the autonomic arousal associated with the transition from sleeping to waking up. Smartphone versions are available for dawn simulation, but it has not been well studied. Maybe the function is same as that of other tested devices. There is a combination of dawn simulator, then blue light environment at night, so that can create a sandwich around the sleep cycle. So both will have a additive added effect. So it will produce more effect than either of these treatment used alone. So all these are what I discussed. Battery down, battery, the charging, charging. So far we discussed all mainly about the different type of chronotherapies. Now we will come to neurostimulation. That is the another non-pharmacological medical management in bipolar disorder. Neurostimulation has contributed to the treatment of mood disorders for more than 50 years. The first application is, as all of us know, is electroconvulsive therapy. But now new techniques have been added to this treatment modality, that is repeated transcranial magnetic stimulation and transcranial direct current stimulation. These last two, repeated transcranial RTMS and transcranial direct current stimulation, these are less invasive than ECT. The application and efficacy are well documented in depression and persistent depression, but there are limited experience regarding bipolar depression. It's a valid alternative to pharmacotherapy and as an augmenting agent with other drugs. Now coming to electroconvulsive therapy, it is an age-old treatment. All of us know that it is started by Serletti and Bini in 1938. Here, seizures are electrically induced in an anesthetized patients for therapeutic effect. However, still the mode of action is not very clear. It is recommended for severe depression not responding to other treatments. It is used in the treatment of mania, catatonia. It is a safe, well-established treatment. It is more effective than pharmacotherapy. The acute therapeutic efficacy applies to both manic and depressive episodes. There is some evidence for the efficacy of manic. Usually, ECT is used in unipolar depression, bipolar in the depressed phase. There is some evidence for the efficacy for manic episodes, although it is generally not used for this condition. In electroconvulsive therapy, bilateral electrode placement is more effective than unilateral placement in rapid and ultra-rapid cycling mood disorder and patients who are resistant to pharmacotherapy. Continuation and maintenance ECT, it is used for preventing recurrences of bipolar and unipolar mood disorders. It is very effective in patients not responding to, in both depression and mania. It is effective in patients not responding to adequate pharmacotherapy. It can be used for catatonia, for rapid control of symptoms, especially in suicidal behavior. in severe agitation or violence, which will put the life of others at risk, or refusal to eat or take fluids, which will put the patient's life at risk. If there is a history of good response to ECT in the past, it can be used as an augmentation if there is partial improvement with pharmacotherapy, and it can be used if the patient is not tolerating pharmacotherapy. So these are the indications for ECT in bipolar disorder. And now some other indications are, definitely we can use ECT in treatment-resistant illness, and in cases of depression and mania during pregnancy. If other drugs are contraindicated, definitely we can use ECT. Side effects are comparatively very rare, especially amnesia, which is retrograde amnesia for recent information, but generally it will resolve within 6 months. Cardiac arrhythmia can happen. Cardiac asystole immediately after ECT can happen. We can prevent it by giving atropine. Sometimes, rarely, prolonged seizure can happen, can develop. Usually, the prolonged seizure can last for more than 3 minutes. Then we have to give anticonvulsants. Sometimes we have to anesthetize the patient. We have to give scoline if the seizure is continuing. But such an incident is very, very rare. Now, the evidence for efficacy in bipolar depression, we have got many studies open, especially in bipolar mania I'm talking about. Open studies are there, case reports are there. Response, it is reported as low. Some responders might benefit from maintenance ECT. In treatment-resistant bipolar disorder, bipolar depression, bipolar mania, if the patient is not responding adequate to pharmacotherapy, mood stabilizer, there is a scope for maintenance ECT in bipolar. Maintenance ECT can also be considered in patients who have responded to the acute phase. If the patient has responded initially during the acute depression or depressed phase, we can consider these people for maintenance ECT. Now, coming to the another technique is neurostimulation, is repeated transcranial magnetic stimulation. It is developed in 1985 based on the effect of electromagnetic fields on neurocortical excitability. Unlike ECT, TMS is a relatively focal therapy. Only a focal area of the brain is stimulated. Here, the stimulation is targeted on a specific area, such as dorsolateral prefrontal cortex, which is implicated in depression. This is the diagram, an example for transcranial magnetic stimulation. You can see the magnetic field here. We can see the brain. We are inducing the current for inducing a magnetic field here. This is the TMS coil. The antidepressant mechanism of TMS is also not well understood, but studies indicate that the effect may be through the serotonergic, dopaminergic, and brain-derived neurotropic system. The most commonly used protocol is stimulation intensity, which is equal to the motor cortical threshold, which may be specific for each patient. There is a rapid frequency of 15 to 20 hertz is used. The total pulse number that varies between 600 to 1800 per day. The usual course of treatment is usually up to 3 weeks. There will be 10 to 15 sessions with 1 session daily. TMS is usually reserved for mild to moderate depression, not for psychotic depression, not for severe depression, not for suicidal depression. It can be used as an augmentation to antidepressant drugs, or it can be used alone. It may be an alternative to ECT, but not as effective as ECT in drug-resistant non-psychotic depression. But it is a safe modality of treatment. Compared to ECT, the cognitive side effects are minimal. There is no need for general anesthesia. There are sporadic reports of induction of mania. There is no data regarding the use of RTMS in rapid cycling bipolar and ultra rapid cycling patients. Contraindications are generally very few, but if there is a history of epilepsy, there is a risk for seizure. In patients with a cardiac pacemaker, defibrillator, or other electronic devices, it is contraindicated. Side effects are generally very minimal, but some patients, it can produce headache and sickness. Now, what about transcranial direct current stimulation? Usually it is known as TDCS. It is developed more than 50 years ago, mainly in tension, headache and all. Many people are using for putting the patient into a uh, relaxation therapy also it has been used, but only in the last few years it is re-evaluated as an antidepressant therapy. It is only a direct application of a relatively weak electric current of 1 to 2 milliamperes. Actually, the equipment is very simple with a small torch, pen torch like battery with the two electrodes, one anode and one cathode. This is the usual TCDS machine. Actual machine, the original machine is very expensive, but we have got very indigenous locally made machines are available from Bangalore that will cost only 15,000 rupees. It is available now. The efficacy of TDCS is controversial. Some studies indicate a definite antidepressant effect both in acute phase and as a continuation therapy in bipolar depression with an onset of action which is faster than other drugs. Only few studies are there on its efficacy in bipolar depression. However, there is a positive effect of a TDCS in cognitive performance, not only in bipolar disorder, even in schizophrenia, even dementia also, studies are there improving cognitive performance with the TDCS. Now, when we come to the third part, that is invasive therapies. Invasive therapies are mainly deep brain stimulation and vagus nerve stimulation. In psychiatry, both are at the experimental level. So the studies are very limited. RCTs are very limited. So we don't have much evidence in bipolar disorder in terms of its efficacy and tolerability. Now, when we look at deep brain stimulation induce a selective and topic modulation of neuronal areas, which is involved in the pathogenesis of depression via electrodes which are deeply implanted directly into the brain, mainly into the emotional circuit of the brain, mainly in the midbrain area. And there, uh, a constant pulse of electricity, small dose of electricity is generated by using the self-implanted electrodes. Deep brain stimulation actually is a neurosurgical tool which is used mainly in Parkinsonism and other movement disorders, which was there in use for the last 25 years. But now, for the last few years, it has been tried in different psychiatric conditions as well, where a small amount of electricity is used to disrupt the activity of the brain structures that produce a that will produce troublesome symptoms. However, promising results are reported in major depressive disorder, but only there are only few studies regarding its efficacy in bipolar disorder. Clinical studies are going on regarding the efficacy of deep brain stimulation in bipolar disorder in US. Now, another deep stimulation technique is vagus nerve stimulation. It requires implantation of a neurostimulator similar to a pacemaker, but here it is connected to vagus nerve. So in vagus nerve stimulation, which was initially used in treatment of refractory seizures, now it has been tried in the treatment of treatment-resistant depression. Efficacy in bipolar disorder, again, not very proven in RCTs. Confirmation of its therapeutic efficacy in bipolar disorder that needs further studies. There are no data regarding the use of vagus nerve stimulation in rapid cycling patients. So with this, I am summarizing. So we know that bipolar disorder is a very complex disease. We have got bipolar depression, bipolar mania, we have got bipolar 1, 2, 3, 4, like that. We have got rapid cycling, ultra rapid cycling, ultra rapid cycling, mixed affective state. So from this, we can see that bipolar disorder is a complex disorder. So that requires multiple level management, different modalities of treatment and intervention. That is why even non-pharmacological, non-pharmacological, and even psychological treatment has been tried as either alone or in combination in this bipolar disorder complex. The non-pharmacological medical management of bipolar disorder, like as I told you earlier, sleep deprivation therapy, light therapy, dark therapy, and other type of therapy, neurostimulation techniques. Uh, uh, all these are maybe safe and valid alternatives to other pharmacotherapy with a low rate of side effects, with a subjective perception of safety. Most of these studies, there is a subjective satisfaction, and subjects are reporting very high safety of these treatment modalities. So we have to explore what will be the utility of these treatment techniques like neurostimulation, invasive therapy. So these are all still under experimental level. So what I can say that in our setup, we know that light therapy is not very expensive. We can definitely implement this therapy in our routine day-to-day practice. Even dark therapy is also that doesn't need any expensive gadgets. Sleep deprivation, all these we should try. We should try along with our pharmacotherapy in our day-to-day clinical practice. So we should explore further in this area. There should be studies from our country also regarding the efficacy of all these treatment modalities in bipolar disorder. Not only in bipolar disorder, can be tried in many other psychiatric conditions also. There should be studies that should come from our place also. So with these words, I am concluding. Thank you for the patient listening.
Thank you. Thank you very much, Dr. Suresh Kumar. I think it's quite a comprehensive presentation. And then there are a few questions, but I think, as I said, this is a very interesting thing. But management of acute phase, mostly it's no depression you talked about. DBS and then vagus nerve stimulation are invasive. RTMS, like an instrument is a little bit on the costlier side, but TDCS is very, very useful. There are quite a few questions on, especially, I think we'll take up the questions for Dr. Suresh Kumar first, and then maybe later move on to Dr. Vikas. I think a very, very valid question. 36 hours, how do you keep the patient at a stretch for the sleep deprivation? And also, what is your clinical experience in this? Because these are very interesting, whether it is light therapy or blocking that blue light and then sleep deprivation. Very simple measures. Are they really effective? Number one, in the acute episode. Number two, what is their role in the maintenance phase also? How long do we give? That's, I think, a few questions have come. If you can answer, what is your personal experience? Do you try this in the management of bipolar disorder?
Sir, myself, I have not tried the management by using light therapy and sleep deprivation also. But in our center, in Central Institute of Psychiatry, Ranchi, there was a study, so the efficacy of sleep deprivation therapy in depression and the dark therapy in mania. It was done by Dr. Khanna, Rakesh Khanna. It was published that time in Archives of General Psychiatry. Then efficacy of amber lenses in mania, treatment of mania, was done at the same time by Rakesh Khanna, and that was published in American Journal of Psychiatry also. So we were wondering, manic patients, there were quite severe manic episode patients, very hyperactive. In fact, they were not obedient. Those patients, they were wearing a cooling glass like thing, and they were moving around our campus, Central Psychiatry Ranchi. But many of these patients, they were cooperative for this treatment. So that study, it was found that even manic patients, we can treat by ask them to wear this sort of amber lenses. So if we can try in our day-to-day clinical practice, may not be in severe manic cases, but definitely hypomanic patients, those patients who do not want high dose antipsychotic therapy and all, those selective patients, very cooperative patients, still, since the gadget is not very expensive, we can try for all these patients. And coming to sleep deprivation therapy, it was, there are many patients who do not want pharmacotherapy. Many patients are very scared of the side effects of antidepressants. They want to go for non-pharmacological therapy like cognitive behavior therapy and all. So in those patients, instead of adding any antidepressant drug, pharmacotherapy, if we can combine sleep deprivation therapy in very cooperative patients,
Yes.
we can combine sleep deprivation therapy with cognitive behavior therapy or any other psychological modality that we can try actually.
Right. I think now, look, what you're saying is that definitely, see, if there is a clinical usefulness and the approach and then management, keeping the patient for 36 hours is a relatively simpler procedure and acceptable to the patient, I'm sure a lot of patients will go, because generally the thing is that there is some kind of a huge kind of a negative thing for the pharmacotherapy. Everybody wants to try something. That is where, like, I think a lot of questions were there, like, how do you manage for 36 hours? How do you keep the patient? No, that's what the personal experience they were asking. Uh, did you try it at least in one patient? By what methods will you keep them awake? I think that Dr. Rahul and Dr. Rangadi, both of them were asking. How do you keep the patient for 36 hours awake?
In Ranchi, Central Institute of Psychiatry, when this study was conducted, we were giving the magazines. We were asking them to engage in small Ludo like game and all. We were asking them to play cards and other games. And in fact, they were willing, they were cooperative. So there is no question of how we can engage these patients for 36 hours. They themselves found out some mechanism to keep them engaged for 36 hours. Because all these patients were very cooperative. And in fact, they were not willing to start any pharmacotherapy. That's why we gave them this option to start this sort of therapy. So
That really will be interesting. And then magazines, even we will end up sleeping. Yeah, somebody said that's right. I know that, Dr. Rahul, I think whatever the questions you asked are very, very practical. And then I understand, like, it's not going to be so easy. But maybe with a very small group of the cooperative patients, maybe we can try. And there are one or two questions for Dr. Vikas also. One is that what is the dose of lurasidone in the management of mixed picture? There's another question about how do we manage the delirium tremens. I think when it comes to delirium tremens, first priority will be management of delirium and then going on to the management of mood disorder. But what is the dose of lurasidone? That's what the question was. For Vikas, would you like to answer that? And also another interesting question: how do you, if there's a comorbid ADHD, I think that Anup, I'll say that it's not like, even mixed itself is a very difficult thing. Now, mixed with ADHD, I think you put really Vikas in a spot. Because, over to you. Please answer that.
Yes, sir. Both are very interesting questions. So the first one is dosing of lurasidone. So if you see, in the real world, most people may start with 40 milligrams for bipolar depression, but sometimes side effects like akathisia can be a limitation when starting and up-titrating lurasidone. So this has been found to be better when you start lurasidone at 20 milligrams. So when we start, so I usually start lurasidone at 20 milligrams and then up-titrate. Most of the time I have found that at doses around 60 to 80 milligrams, there is some response. But having said that, the response I have found with lurasidone is not that impressive. That's why I often start SSRIs also when I come across a case of depression. But yes, if you're trying lurasidone, maybe the dose range that is recommended is 20 to 120 milligrams. Another one very interesting thing about lurasidone is you have to give it along with food. So it is probably one of the other important drug which is also recommended for bipolar mixed states, ziprasidone. So you can remember that sidone, that is how I remember, lurasidone and ziprasidone. These are two drugs where the bioavailability is increased when you take it with food. So that is another interesting consideration. So I asked them to take 3 idlis. I ask patients to take 3 idlis and then consume the lurasidone, because 3 idlis will roughly amount to about 300 to 350 calories. So that is the meal that they have to take. So if you can dose lurasidone probably in this manner, then it may be beneficial for mixed states. That's the first question. Then the second question was how did it influence management in comorbid ADHD? So in comorbid ADHD, or generally, in pediatric bipolar states, yes, you have to think about you have to keep in mind that there may be an increased risk for bipolarity, increased chronicity, and increased switch rates and all. Atypical antipsychotics, just risperidone, olanzapine, aripiprazole could be a good starting choice for mixed states in pediatric bipolar. Evidence is very less. I think there is one study called TEAM study, treatment of early age mania or something. So that is one of the few studies which have evaluated mixed states also in pediatric groups. So atypical antipsychotics maybe should be your first choice there.
There are, I think, is one more question maybe, but it's not directly related to this about yoga and meditation. Will it be, can you meditation, yoga worsen mood disorders? Or at least does it help in the maintenance phase? I think one of you can answer that. Maybe Suresh can answer that.
Yes, sir. See, in Kerala, one of the treatment modalities many people, non-doctors, they are suggesting is art of living. So many of our psychiatric patients, especially bipolar disorder patients, who are on therapy with mood stabilizer as a treatment suggested by non-doctors, they will join for art of living therapy. There is something like Sudarsana Kriya and all. These are almost like meditation. So what we have seen that many of these patients, despite being on regular treatment of mood stabilizers, many of these patients after starting the Sudarsana Kriya, say deep breathing technique, many of them have been switched to manic episodes. So by seeing that, we searched the literature, then we found that in bipolar disorder patients, when they are undergoing yoga, meditation and all, that can increase the energy level. And this increasing the energy level, that can precipitate a manic episode. We have seen that. Not only that, many religious treatment also, they will be doing, they will put the patient to a trance-like state and all. They will keep the patients in continuous religious chanting and all, without sleeping and all. So many of these patients, despite on regular treatment, we have seen that they will be going into something like a mania-like picture. So what I would suggest that in bipolar disorder, it is not good to go for yoga. If it is only unipolar depression, it is better that they can, as a additional treatment, or they can go for yoga or meditation and all. But in bipolar disorder, it is not advisable to go for yoga because it can increase the energy level. Maybe that can produce manic switch.
Yeah, thank you very much. I think I'll also agree with you because, another worry for me is that generally when you go for this, one of the common suggestions from them is stop all the medicines and then we'll manage with yoga or meditation, which can be kind of a disaster. Maybe we'll take just the last question. After keeping them awake for 36 hours, will patient get sleep automatically or do they need supportive medication to sleep? There's a question to Dr. Suresh. I think this will be the last question. After that, we'll now over to interspecies. Do they need medication to sleep after 36 hours or they sleep off automatically?
After 36 hours, there is no need to give any medication to sleep. They will automatically sleep because see, towards the end of 30, 35, 36 hours like that, it is very difficult to keep them awake.
Correct.
So by 36th hour, they will automatically go to sleep. There is no need for any other additional medications.
Right. I think there are no more questions. And then over to Dr. Kishore from Intas. Thank you very much, both the speakers.
Yes,
and
yes, sir.
Thanks. Thank you so much.
Thank you.
So
Thank you. Thank you, sir.
Thank you very much for this wonderful presentation over here. Now I ask Mr. Jagrup Singh, who is Senior VP, Aquila Division Intas, to deliver the vote of thanks.
Thank you, Dr. Kishore. Thank you very much. Sir, on behalf of Intas, I extend my gratitude to the eminent moderator and both the eminent speaker, which were making this webinar so informative and quite engaging also. And as you know that without any webinar is incomplete without participants. My special thanks to all the participants. Basically, your participation always encourages us to do such a fantastic scientific activity. So thanks a lot. Thank you very much, sir.
Thank you. Thank you and
Thank
good
you.
luck to all.
Thank you.
Thank you, sir.
Thank you, sir.
Yeah.
Thank you.
Thank you.
അവരോട് ചോദിച്ചാൽ